Welcome to this presentation on respiratory failure, laboratory tests, and diagnostic procedures. Today, we're going to discuss the essential diagnostic tools and laboratory tests that are crucial for the diagnosis, monitoring, and management of respiratory failure. Respiratory failure is a critical condition that necessitates accurate and prompt detection. The information obtained from these tests will guide the healthcare team in implementing the most appropriate and effective treatment strategies. It's important to remember that interpretation of these laboratory tests must be performed within the context of the patient's clinical condition, and any abnormality should be correlated with the patient's signs and symptoms. So let's look at an overview of the key tests and procedures that are fundamental in assessing patients with respiratory failure. So we often rely on a combination of laboratory tests and diagnostic procedures. Arterial blood gas analysis is an essential laboratory test to evaluate the patient's respiratory condition. The test gives us insight into the levels of oxygen, carbon dioxide, and their blood pH. It's critical in diagnosing both acute respiratory failure and acute respiratory distress syndrome, as well as conditions like severe acute respiratory syndrome. Next, we have imaging studies such as chest x-rays. These provide invaluable visual data about the patient's lungs. Changes such as pulmonary edema, cardiomegaly, and infiltrates can often be seen in patients suffering from acute respiratory failure, acute respiratory distress syndrome, and severe acute respiratory syndrome. Electrocardiogram is another diagnostic procedure used to rule out any cardiac involvement that might be contributing to the respiratory condition. Hemodynamic monitoring is crucial for assessing fluid status and cardiac function. The pulmonary capillary wedge pressure is particularly important in cases of ARDS. As healthcare providers, we are tasked with performing certain nursing actions to ensure that these tests and procedures are carried out effectively. These include assisting with patient positioning, communicating results promptly, monitoring the ECG during the placement of central venous pressure catheters, and more. Arterial blood gas analysis is a critical laboratory test. It provides us with immediate information about a patient's acid-base balance, oxygenation, and carbon dioxide elimination. In the context of acute respiratory failure, acute respiratory distress syndrome, and severe acute respiratory syndrome, ABGs help us to diagnose and monitor the severity and progression of these conditions. We need to look for specific changes in the partial O2 and partial CO2 levels, along with what the pH is, to identify hypoxemia and hypercarbia. So in general, if a patient's PaO2 is less than 60 millimeters mercury and their oxygen saturation is less than 90% on room air, this indicates hypoxemia, a lower than normal level of oxygen in the blood. Similarly, if a patient's PaCO2 is greater than 45 millimeters mercury and their pH is less than 7.35, this indicates hypercarbia, an excess of carbon dioxide in the blood. This also indicates the presence of respiratory acidosis, where the body's ability to remove carbon dioxide is impaired. It's important to note that in acute respiratory failure, we can see either hypoxemic, oxygenation failure, or hypercapnic, ventilatory failure, or sometimes a combination of both. Think about this. Hypoxemia, is an oxygenation failure. Hypercapnia is a ventilatory failure, and your patient can have one or both. For hypoxemic failure, the partial O2 is typically less than 60 millimeters mercury on room air, and the SaO2 is less than 90%. For hypercapnic failure, this is your ventilatory failure. PaCO2 is typically greater than 45 millimeters mercury with a pH of less than 7.35. Monitoring changes in these parameters over time is crucial in managing these conditions, as it helps us to gauge the effectiveness of interventions and adjust our treatment strategies accordingly. As healthcare providers, we need to understand these changes in ABG values, what they signify, and how to respond to them to optimize our patient outcomes. Acute respiratory failure is a life-threatening condition that occurs when the lungs can't provide the body's vital organs with enough oxygen, or when the lungs can't remove carbon dioxide from the blood. It can lead to organ dysfunction, and in severe cases, it can be fatal. Our ABG analysis is a cornerstone diagnostic tool for detecting and monitoring ARF. This test assesses the amounts of oxygen and carbon dioxide in the blood, as well as the acid-base balance. Remember, in ARF, we're going to find two types of failure that can be identified through our ABG readings: our hypoxemic, our oxygenation failure, and our hypercapnic, our ventilatory failure. Remember that in hypoxemic respiratory failure, the main problem is inadequate oxygen levels in the blood. And so on room air, a patient would have a PaO2 of less than 60 and an SaO2 of less than 90. I know I'm repeating myself, but I really want you guys to get this. On the other hand, hypercapnic respiratory failure, also known as ventilatory failure, involves an excess of carbon dioxide, PaCO2 greater than 45, and a decrease in blood pH less than 7.35. And this indicates respiratory acidosis. So the respiratory system is failing to eliminate enough carbon dioxide, which is an acid, which is resulting in a buildup in the bloodstream, aka respiratory acidosis. These two types of failure can occur separately or simultaneously, and when both are occurring together, it represents a particularly severe case of acute respiratory failure. So it's essential that you understand these values. They provide us with the insights we need into the severity of the patient's condition, the underlying cause of respiratory failure, and how well the patient is responding to treatment. Closely monitoring these values is necessary as a guide for our therapeutic interventions, and we need to ensure that the patient's respiratory status doesn't continue to deteriorate. Diagnostic procedures are crucial for confirming a diagnosis of respiratory failure and identifying the root cause. Their objective is not only to confirm the presence of the disease, but to understand the extent of lung damage, evaluate the heart's function, and to rule out other potential causes or complications. For patients suspected of having acute respiratory failure, ARF, acute respiratory distress syndrome, ARDS, or severe acute respiratory syndrome, SARS, multiple diagnostic tools are employed. They provide a comprehensive picture of the patient's overall health status, which will aid in determining the most appropriate treatment approach. The two main diagnostic procedures are chest x-ray and electrocardiogram. Each has its own set of benefits and limitations. The information they provide is complementary to our care. So in other words, it's not about choosing one over the other, but using them together to get a more complete and accurate clinical picture. So our chest x-ray offers a non-invasive way to visualize the structures within the chest, including the lungs, the heart, and the major blood vessels. It can reveal abnormalities associated with ARF, ARDS, or SARS, such as pulmonary edema, cardiomegaly, or diffuse infiltrates. An electrocardiogram is another non-invasive test that records the electrical signals in your heart. It's a valuable tool for detecting heart conditions that may be contributing to or resulting from respiratory failure. It can help to rule out cardiac involvement, and this is especially important because there are heart conditions that can either mimic or exacerbate the symptoms of respiratory failure. Another essential diagnostic tool is hemodynamic monitoring. This is used to assess the patient's cardiovascular function and fluid balance, particularly in patients with ARDS. This monitoring can help to manage fluids effectively, as fluid overload can worsen respiratory conditions. As healthcare providers, our role includes assisting with these diagnostic procedures, interpreting results, and communicating findings effectively among the healthcare team. So, a chest x ray is one of the first diagnostic tools utilized in suspected cases of respiratory failure. It's a non-invasive imaging technique, provides a quick, efficient means of visualizing the structures within the thoracic cavity, including the lungs, the heart, and major vessels. When evaluating the X-ray image, we're looking for signs of abnormalities or pathologies that could be contributing to respiratory failure. These might include areas of opacification, changes in lung volume, changes in heart size, or abnormalities in the major vessels. In the context of acute respiratory failure, acute respiratory distress syndrome, and severe acute respiratory syndrome, specific changes can be expected to show up on your chest x-ray. Pulmonary edema. This condition presents as increased shadowing in the lung fields. It often appears as hazy opacities, typically more prominent in the lung bases, including fluid accumulation in the alveoli. Cardiomegaly. In cases of ARF, an enlarged heart might be seen on the chest x-ray, which can point to heart disease as a contributing factor. Diffuse infiltrates or ground glass appearance. In ARDS, the lungs may show diffuse bilateral infiltrates, sometimes described as a whiteout appearance, or ground glass opacities. This represents fluid accumulation and inflammation throughout the lungs. In cases of SARS, areas of infiltrates might be visible. These areas of increased density in the lungs can indicate infection or inflammation. As part of the healthcare team, our role involves assisting with client positioning before and after the x-ray to ensure optimal imaging. It's also important to communicate the results to the appropriate personnel in a timely manner, as these results can significantly impact the patient's treatment plan. It's worth noting that while chest x-rays are a valuable diagnostic tool, they should be interpreted in conjunction with the patient's clinical presentation and other diagnostic findings. This approach will help us to provide a more comprehensive picture of the patient's health status. Reading x-rays is something that takes a lot of time, experience, and practice. It is not something you are expected to be able to do right off as a brand new nurse. I just wanted to show you some basic pictures of what some of this might look like so that you have some idea what we're talking about. This is pulmonary edema. This is cardiomegaly and also bilateral pulmonary edema. So you can see how the heart is enlarged and kind of pushing on the lung and making it more difficult to oxygenate. This is your bilateral diffuse pulmonary infiltrates. And this is your bilateral ground glass opacities. An ECG is another essential diagnostic tool we utilize to help discern the cause of a patient's respiratory distress. Remember, in respiratory failure, the heart and the lungs are intricately linked, and issues with one can often cause or exacerbate issues with the other. This diagnostic procedure helps us to rule out cardiac involvement in the symptoms of the patient. An ECG measures the electrical activity of the heart, allowing us to detect any heart rhythm abnormalities. These are called arrhythmias, which could be contributing to the patient's condition. In situations where the heart is unable to effectively pump blood to the lungs, the blood oxygen levels can decrease, leading to symptoms of respiratory distress. Conditions like heart failure or heart attack can present with symptoms similar to respiratory failure, such as shortness of breath. Therefore, it's crucial to rule out these conditions as the primary cause. During the ECG procedure, the patient will be connected to the ECG machine using leads placed on their skin. We as nurses play a crucial role in ensuring the patient's comfort and understanding of the procedure. We need to explain the process to the patient, reassure them that it's painless, and respond to any concerns they may have. Throughout the ECG, we monitor the patient's vital signs and watch out for any symptoms of discomfort. We need to interpret the ECG results or ensure they are delivered to a healthcare provider who can. Post-procedure, we need to observe the patient for any changes in their condition. It's essential to explain to the patient that the ECG is one part of the diagnostic picture and that additional tests may be needed to fully understand their condition. Finally, it's important to communicate the results of the ECG to the relevant healthcare providers in a timely manner. This helps to expedite decision-making and initiation of treatment, potentially improving patient outcomes. Hemodynamic monitoring is a sophisticated and essential method for measuring the amount of blood that the heart is pumping, the volume of blood in the blood vessels, and the oxygen level in the blood. This information is vital for understanding the patient's fluid balance and for tailoring their treatment plan in the context of respiratory failure. In conditions like acute respiratory distress syndrome, we are particularly interested in the pulmonary capillary wedge pressure, or PCWP. This measure gives us insight into the left ventricular end diastolic pressure, which is an indirect measurement of the left ventricular preload. I know these are a lot of words. We are going to get into them in more detail when we discuss cardiac issues. Essentially, we're looking at the volume of blood in the left ventricle at the end of when it fills up, just before contraction. A PCWP within the expected reference range, which is 4 to 12, or lower than expected, is typical in ARDS. Hemodynamic monitoring is typically done using a central venous pressure catheter or a pulmonary artery catheter, sometimes called a Swan-Ganz catheter, which is inserted into a large vein. This catheter provides continuous measurements of important parameters such as cardiac output, systemic vascular resistance, and intracardiac pressures. During placement of the central venous catheter and hemodynamic monitor, the nurse must keep a keen eye on the patient's ECG to quickly identify any complications that might occur. Being prepared is essential. Having resuscitation medications and equipment available is crucial in case any emergencies arise. Post-placement, the nurse is responsible for monitoring hemodynamic waveforms and readings, ensuring that the equipment is functioning correctly and that the readings are accurate. It's important to continually cross-check the monitor readings with the patient's clinical signs, symptoms, and other diagnostic test results. It's also vital to confirm catheter placement using a chest x-ray to ensure that it is in the right position and not causing any harm to the patient. This confirmation is usually done immediately after catheter insertion. The nurse must remember that while hemodynamic monitoring provides valuable quantitative data about the patient's cardiovascular status, it is not a replacement for thorough, regular patient assessment. It's another tool in our kit to understand and respond to our patients' needs better. Hemodynamic monitoring, because it's an invasive procedure, entails certain nursing responsibilities. First and foremost, you should ensure the patient's safety and comfort during catheter placement. Make sure to explain the process to the patient, answer any questions they might have, and reassure them throughout the process. Be vigilant when monitoring the electrocardiogram during the placement of the central venous pressure catheter and hemodynamic monitor. This is important because changes in the ECG can provide early warning signs of complications, such as if we have punctured the heart or the lungs. Ensure that resuscitation medications and equipment are readily available. As with any invasive procedure, complications can occur, so being prepared is paramount. This is especially true when working with critically ill patients who are already physiologically compromised. And let's be real, we're not going to be doing these procedures on perfectly healthy individuals. Once a catheter is in place, it's your responsibility to monitor the hemodynamic waveforms and readings. Pay particularly bleh, pay particular attention to sudden changes, as these could indicate a problem like dislodgement of the catheter or changes in the patient's condition. Ensuring that the catheter remains in the correct position is vital, so a chest x-ray should be carried out to confirm this after the initial placement and periodically afterwards or if complications are suspected. Inform the radiology department and the provider immediately if the x-ray suggests that the catheter is misplaced. Remember that the catheter is an open route into the patient's bloodstream, so infection control is of the utmost importance. Regularly check the insertion site for signs of infection, such as redness, swelling, or discharge, and keep the area clean and dry. Lastly, continually assess the patient's comfort and manage any pain associated with the procedure. This not only involves pain management, but also includes elements like helping the patient find comfortable positions that do not interfere with the catheter or the other monitoring equipment. So as we wrap up this discussion on laboratory tests and diagnostic procedures for respiratory failure, it's essential to emphasize the central role these tools play in identifying and managing the condition. We start with our ABGs, where we get insights into the severity of the hypoxia, the hypercarbia, and the acidosis associated with respiratory failure. These results are crucial in managing patients' oxygenation and ventilation needs. Notably, persistent values outside of the normal ranges signify acute respiratory failure. Chest x-rays and ECGs provide us with critical information about the structural and functional conditions of the heart and lungs, helping us to identify any other conditions that might be contributing to respiratory failure, such as pulmonary edema or cardiomegaly. Hemodynamic monitoring, even though it's more invasive, provides real-time information about fluid status and cardiac function, assisting in timely interventions to prevent further complications. And as nurses, our role goes beyond performing these tests. We play a pivotal role in ensuring patient safety during these procedures, communicating results, interpreting data, and coordinating with the entire healthcare team to ensure prompt and appropriate interventions. Remember, you are the eyes on the patient at the bedside. As we've seen throughout this presentation, timely and accurate diagnosis supported by these lab tests and procedures is the key to ensuring the best possible outcomes for patients with respiratory failure. So thank you for your attention and participation. I encourage you to revisit these notes and reach out to me if you have further questions.